We're going to talk Dr. Hiremath and Dr. Patel. I don't remember who's going. Okay, Dr. Hiremath will be going first, talking about some current but also next level applications of deep brain stimulation and high intensity focused ultrasound as therapeutics. We had the opportunity to visit a company that is at the forefront and get some insider information about things that are on the way, and it's very, very exciting, and I think will be very therapeutically helpful. And Dr. Hiremath, come on up, neurosurgeon at OhioHealth, who is just a phenomenal neurosurgeon who has helped us and helped many people immensely. So come on up and tell us a little bit more about the next level DBS.
Thanks, Dave. Appreciate it for those kind words. All right. Thank you, everybody, for coming on Saturday. Along with the team at Riverside, we started doing this surgery for Parkinson's disease about 5 years ago. So I'd like to just talk a little bit about what we've done, just a brief introduction of deep brain stimulation and where we think it's headed. I don't have any disclosures. So what is deep brain stimulation? Sorry, there's an echo, I think. You can think of it at a very basic sense as a pacemaker for the brain. People have abnormal rhythms in their heart. They wear a pacemaker to sort of settle down some of those abnormal rhythms. And we think that Parkinson's, as a result of the lack of this chemical called dopamine, runs some abnormal circuits in the brain. And so in an attempt, we try to settle down those abnormal rhythms and establish a more normal motor outcome for people with Parkinson's disease. Who does it help? It helps people who have Parkinson's disease, that is idiopathic Parkinson's disease, for whom dopamine is helpful or was helpful. And so if we have a sort of what we call atypical Parkinson's disease and dopamine wasn't really effective, DBS probably may not be effective, except people who have what's called tremor-predominant Parkinson's disease. They don't have the stiffness and the slowness associated with Parkinson's disease, and most of their Parkinson's is purely tremor, and it certainly helps with those symptoms as well. We usually wait about 4 years after the diagnosis just to make sure that patients are not having any of the atypical versions of Parkinson's disease, because it can be a little tricky to diagnose. This is what I call my good luck slide. This is Dr. Benabid. He is sort of the guy that first did this operation in France, in Grenoble, France, in the late 1980s, initially for tremor and then for Parkinson's disease. I met him at a conference in Scotland many years ago, and so having this picture, I think it's our good luck. We've had a successful program, so every time I give a talk, this picture makes its way into the slides. So what is the goal? The goal of DBS is to get to your best on time without the extra movements and with minimal on-off fluctuation. We improve all the three cardinal symptoms of Parkinson's disease: rigidity, the slowness, the stiffness, bradykinesia, the slowness, and the shaking. Some patients are able to reduce their dopamine dosing. Some people are not. Just sort of depends on which target we use. And just sort of referring back to the previous talks, motor symptoms of Parkinson's, that's the tip of the iceberg, right? Then there's all these non-motor symptoms. And certainly it doesn't improve non-motor symptoms, and it has a very challenging time affecting freezing of gait, which I'll talk about a little bit later. We think it lasts about 10 to 15 years until the disease itself continues to progress. So how does it work? We don't know, actually. So we think that there's two circuits in the brain that allow smooth movement, and what it does is that Parkinson's disease activates sort of the abnormal circuit that makes smooth movement difficult. That's why people have the slowness and the stiffness. And so there's sort of three primary targets that we use with DBS to try to alter some of the way these circuits are working. It may affect electrical, chemical, network properties. It may reduce abnormal patterns. We know now that there's some abnormal rhythms, what's called a beta frequency. It's about 15 to 30 hertz that these neurons are firing at. And when I was in Oxford, sort of as we were trying to learn to try to build our program, I spent a couple weeks in Oxford many years ago, and there was a guy named Peter Brown who's a neurologist, and he found out that there's this abnormal rhythm called a beta band, and it's associated with the off state of Parkinson's disease. It improves when people take their medicine. And so that can be used as a biomarker to target DBS therapy. And so that was sort of like a picture in the future, and now we're actually starting to begin to use it. So the 3 hallmarks of a successful DBS operation is choosing the right patient, making sure that, my job in those 3 things is making sure I place the electrode in the right target. And then the third thing is, Dr. Hinkle and Dr. Hardwick, who's my partner in crime, successfully programming it. How do we know DBS works? Well, we have good literature. People think of DBS as this new treatment. Well, it's not new. It's been around for 30 years, and hundreds of thousands of people across the world have benefited from this treatment. There are good randomized trials, which I can't say for a lot of the surgeries that I perform, but for DBS, absolutely. It's better than medical treatment. So this study from Germany, published in New England Journal of Medicine in 2006, it shows us that, let me see if this. So if we look at people who were managed with medicine, that's the light blue. If you look at all these quality of life measures, the people who had DBS have a much better change from baseline. That is, that they're much better functioning in terms of their motor outcome compared to the people who were just managed with medicine about a year out from the surgery. The other way we know that DBS works is one of those great operations where I can turn it off. And if I turn off your DBS, I can tell you how you look like before the surgery. And then I can show you that it's working. So that's sort of current state. So what are we looking at in terms of the future? In some extent, I think the future is now. I think at Riverside, we've tried to adopt a lot of the sort of the cutting edge technology that's coming out. DBS was an operation that was many years ago, maybe 10 years ago, restricted to just a handful of academic centers that were on the cutting edge, but now this is sort of mainstream. We use what's called directional leads. This is a Medtronic slide. So electrodes are placed that we can shape the current, if we're, so just to maximize and maximize the way the current is flowing out of the lead in one direction or the other. And we've been using this for the last maybe 2.5 years. The name of this lead that Medtronic creates is called Sensight. We just had, like Dr. Hinkle was saying, we made a trip up to Minneapolis, and we were sort of given a sort of an inside look at some of the new technology coming out with regard to these leads. These leads are also what's called adaptive or closed loop, which means that they're able to detect that beta band, that biomarker of Parkinson's disease. A little bit more on that shortly. When we talk about what does the future hold, well, what is a traditional operation? Well, this was an operation when I was a resident. It took 8 hours. I was Ali Rezai, who's sort of like the god of DBS. You might have seen him on 60 Minutes. I was his resident, and his DBS operation, we would start at 8 in the morning, we'd finish at 4:30, and that was just the first stage of the operation. Now we do a DBS operation, usually done by around 11 o'clock in the morning. So the traditional operation was, patient was awake, and sometimes we still have patients awake. We had this big contraption. Patient was in a frame, couldn't move, and everything was done by hand. We were changing the arc and the ring of the frame, and I would say most places in the world it's still done like this. And we do what's called microelectrode recording. Each nucleus in the brain has a specific signature, a specific way it sounds. So we have a trained neurophysiologist that comes and helps us and ensures that we're in a good spot where the electrode lands. But more and more, DBS is, it's moving towards less human intervention, just like everything else in the world. So I use a robot, and we've done more than 100 DBS procedures now with the robot at Riverside. I think it vastly improves accuracy because, if I'm measuring 22.5 versus 22.2, the robot can do that better than I can. And so I think, my bias is that it vastly improves the accuracy of the electrode, and really my job is to make sure the neurologist has the best electrode in the best spot possible. So this is a picture of our robot. This is a Neuromate robot. It's produced in France, and with good rep support. We have an engineer that comes and supports the case every time. This is what's called an O-arm. It's an intraoperative CT scan, and it tells me that once I place the lead, I can get a CT scan just in the operating room to make sure that the electrode is actually exactly where I wanted it. And so if you look at this picture, this yellow line is where I had planned the electrode, and the white is the actual electrode. So we're sort of dead on. So this is sort of what we want from every single operation. Imaging advances. So that's the biggest thing. That's what allows us to do this operation in a much more efficient fashion. We can actually see the nucleus, whereas previously we would have to rely on microelectrode recording and coordinates, just sort of estimating based on some known anatomical landmarks where the nucleus is, and we would have to do checks and rechecks. But now, we can see the subthalamic nucleus. It's beautiful, nice and clear. Our imaging technique, we borrowed from Queen Square in London, so we have a specific T2 sequence on the MRI where I can see the nucleus beautifully. So if a patient we don't think can tolerate an awake procedure to confirm we're in a good spot, we can do the procedure with the patient asleep, no problem. I have no problem with that. We have really good targeting accuracy with that. The thalamus is another spot. We can't see the nucleus in the thalamus, and that's why we do it awake, but this is a new study that shows that now we found a spot that we can visualize on imaging. So potentially in the future, we can do all aspects of DBS. All three nuclei that we use, we can probably do it asleep without having the misery of having the patient awake. I'm sorry, I'm running out of time, but might need a few more minutes here. DBS until now it's continuous, right? Whether or not you need the DBS, whether or not you're in an on state or off state, it's constantly on. It's sort of a dumb system because it's just constantly running. And although it improves motor symptoms, having it on when you're asleep, there's some evidence to suggest that probably not the best thing for your sleep, and sleep is one of the most important aspects of the non-motor symptoms of Parkinson's disease. So using this biomarker that I was talking about called a beta band, can we use that biomarker when that biomarker is detected? Can the DBS system be activated, more or less based on the expression of that biomarker to make it a smart system that is much more responsive to the fluctuations of the symptoms of Parkinson's disease? And yeah, the preliminary data is that yes, it's an amazing new technology. This is a study from Germany where they did something very similar. When patients get their DBS, they walk into the neurologist's office a few weeks later. The neurologist usually spends 2 or 3 hours programming the DBS based on just sort of, how patients' symptoms are doing with various different programming combinations. Might be several hundred of these combinations that they might have to try before they figure out the best one for the patient. Usually it takes several months to get that best programming. Well, using this beta peak, this biomarker, the programming can be done in about 20 minutes. And we would be able to serve so many more people with this operation if we were to use this type of programming. Another study from Germany, very similar. So this is sort of that beta peak that we're talking about. And so the new Medtronic lead is able to detect that peak, and we can fine-tune where that peak is noted on the contact of the electrode. So in this one, this is, let's say we find it in the first one, the first contact, well, we can use that contact to deliver the highest current. and in effect have the best chance at relieving motor symptoms. This is another sort of brand new, hot off the press. What other markers can we use? Well, there's another marker called FTG, or finely tuned gamma. This is Phil Starr's group at University of California, San Francisco. He's a neurosurgeon that specializes in DBS. And their group, they found that monitoring, putting an electrode on the brain surface, as well as inside the deep brain nuclei, they found a new biomarker called gamma, which is about 60 to 90 hertz. And this can be used to treat the fluctuations associated with DBS therapy. The other thing is that with the beta band, with the detection, we have to turn the system off to detect it. But this can be used to detect it constantly, even though the DBS system is running. And just in this preliminary study, it resulted in significantly decreased motor fluctuations, and potentially may improve sleep quality as well. Going back to some of the previous talks about freezing of gait, again, DBS is not very effective the way it is right now at helping with freezing of gait. This is another study that shows how DBS may be in the future used to help freezing of gait. This patient has a DBS. He also has what's called an IMU, an inertial measurement unit, taped to his leg muscles. That's linked into a computer, and so there's this thing called arrhythmicity. So, when there's sort of an abnormal rhythm to the muscles when you're walking in terms of freezing of gait, this IMU detects it, signals the computer, and then the computer is then wirelessly connected to the DBS, so the DBS can give you an extra boost of energy during that episode of freezing of gait. So in this preliminary study, they were able to show that the people who wore this device had no freezing events and the lowest gait arrhythmicity without compromising slowness and stiffness. And then lastly, we're used to looking at the brain in regions, in small locations, one nucleus or one part of the cortex. Really, the future is looking at how the brain is interconnected, and physically separate parts of the brain may be highly interconnected. And so stimulating a small nucleus 7 centimeters from the brain may have an effect on the premotor cortex much more so than was initially thought. And really understanding that fingerprint of somebody's connections within the brain is the future of how to optimize DBS therapy. The new word is, you might use this at a dinner party. Feel free to. It's called a circuitopathy. So it's basically a circuit of the brain. There's sort of disease in that circuit. And basically Parkinson's is a type of circuitopathy, just like epilepsy is. And so, finding these connections may help us optimize this type of therapy. All right, thank you. Sorry, I ran over. All right, Dr. Patel.
All right, good afternoon, everybody. So the second part of this talk is focusing a little bit on a different type of surgical treatment option that is relatively newer, and this talk is going to focus more on, well, how can it potentially be beneficial for Parkinson patients? My disclosures are there. I do speak for a few pharmaceutical companies and on the advisory board for AbbVie Pharmaceuticals. So the goal, again, is to look into high-intensity focused ultrasound, which is a relatively hot topic that a lot of patients do come to me asking me about whether this is a treatment option for them and could it potentially help them. So we'll go through kind of what it is, how it works, and what its role is currently and also potentially in the future, how can it be beneficial for Parkinson's disease. So the biggest takeaway today is high-intensity focused ultrasound is a treatment option for tremor, just tremor. Currently, it is approved to treat tremor alone. So a lot of the studies for high-intensity focused ultrasound has been done not really on Parkinson's disease per se, but on essential tremor, which is another movement disorder that is very similar to Parkinson's. These patients have tremor predominantly when they're doing something with their hands. Eating, drinking, writing can be difficult because they're shaking so much. It is one of the more common movement disorders. It can affect their quality of life significantly for these patients. And treatment, medication options don't work as well. Surgical treatments, DBS included, works very well as high-intensity focused ultrasound. So DBS has been shown to be effective to treat Parkinson's disease as well as essential tremor. The target for essential tremor is the thalamus of the brain. And although it is very effective, it does have its own setbacks. It is a surgical treatment with risk of infection, hemorrhage. There's hardware that is placed that patients kind of get anxious about. You know, when you do have DBS, you do want to make sure that you do live somewhere close to a center that can manage DBS well. So there are lots of reasons where patients kind of tend to become a little bit hesitant to go down that route, and then they come to me and say, well, is there anything else besides DBS? A Parkinson's tremor, although it's different than essential tremor, it still can be pretty bothersome for patients. You know, I do still have that conversation with Parkinson patients, letting them know, you know, a shake is just a shake. However, it's embarrassing, it can become debilitating, it's frustrating. There is a role, and we talk about how levodopa can improve your slowness and stiffness, and whatever tremor control we get, great, we take. But the idea behind levodopa is to really improve your mobility overall. But that tremor, there are patients who that tremor is just levodopa resistant. No matter how much levodopa they take, they still shake pretty bad. It could be exhausting for them. And so is there something else that could potentially help with just that shake itself? So high-intensity focused ultrasound, although relatively new, it has been around for many, many years, predominantly in the diagnostic area. The use of HIFU for ablation was back in the 1940s and 50s. They were doing it. It was first applied for Parkinson's disease, where they opened up the skull and ultrasounded the globus pallidus, and they got some decent results with that. However, we don't really want to open up skulls. Is there anything else we could do? So then in the 1990s, they started using MRI and using MRI-guided ultrasound and seeing if we could use that as a potential therapeutic option for patients with certain neurologic diseases. So that's sort of where we are today, and that's sort of the idea behind how this works. So it's an MR-guided focused ultrasound, and the idea is you take high-intensity ultrasound waves under an MRI machine to be able to see exactly where we want the waves to go to cause the lesion to help improve and get that tremor under control. We'll talk a little bit about this towards the end, but there are animal models in terms of future benefits of this. You know, the biggest hurdle we get, and I know they touched on it this morning a little bit regarding things like stem cells and gene therapy and all these things, is, well, the brain is very protected. It is protected by this blood-brain barrier that it doesn't allow a lot of things to get through or get in there. And is there any way we could, to get treatments like stem cells and gene therapy and things, if we could potentially open up that barrier in some way to get these great technologies, these great treatments that are there, can we get it to the brain? Can we help patients to do that? And that's where some of these animal models and the idea behind using ultrasound comes into play, because if you do with low intensity ultrasound waves, that does open up that blood-brain barrier, and now we may have a potential role of being able to use all these other technologies now for neurodegenerative diseases like Parkinson's. So what do we do? How does this work? So sort of the protocol across and what we do here with OhioHealth. So if you are potentially a candidate and you've talked to your doctor that you really want this tremor under control and you would like to have this procedure done, it is still one thing to keep in mind, and I tell my patients, because they say they don't want DBS because they don't want surgery. This is still surgery. I want to make sure everyone understands this is still a surgical procedure. The ultrasound waves are going in and they are burning a hole. It's a literal hole that's being burned in to break that circuit, like what Dr. Hiremath talked about. Same concept, DBS uses it electrically to do it. DBS is technically reversible in the sense you're having an issue, you turn it off, and you're back to kind of how you were. Here, with ultrasound wave, although it's non-invasive, it's burning a hole. And when you burn a hole, that hole is there permanently. So always keep that in mind. So we want to make sure it's the right patient, right candidate, and they're going into it with realistic expectations as to what is the goal here, why am I doing this? So, you get evaluated to see if you're a candidate. You do have to have a CT scan of your brain done to make sure that your skull is not too thick or too thin to be able to have the ultrasound waves be able to penetrate through. On the day of the procedure, you meet with the surgeon who would, you still have to shave your head, and they inspect to make sure there aren't any scars or anything that could potentially cause an issue with the ultrasound waves to go in. You have this elastic diaphragm that's placed, that's filled with cool water for the ultrasound to work as a transducer for the ultrasound waves. And then you're put under an MRI machine. You're awake throughout the whole time. We want you awake because I'm there or Dr. Hardwick, who we want to see your tremor. We want to see it bad. We have you do the spirals and have you do all these things because we want to make sure as we're targeting, we're trying to get that tremor under control. So we want you completely awake to do this. So it is done under MRI. In the beginning, when you're laying there with the surgeon, they're mapping out to see which area, where are we going in under the MRI machine. In the beginning, there's these low waves that are first being, that are first started off, and these are test lesions. So we go in and see, okay, are we getting some control? Yes, we're getting some control, but these are not permanent. These are just temporary lesions that are being made. They go away, your tremor returns, just so we want to make sure we're in the right area, we're not having any side effects, any numbness, weakness, anything like that. And before we go in to do the final high intensity, high temperature to actually burn the lesion. Overall, this could take about 3 to 4 hours. The neurologist, Dr. Hardwick, or myself is there monitoring to make sure you're not experiencing any other effects besides just getting that tremor under control. And this video kind of shows a little bit of that. It's a marketing video, so it's gimmicky. So it's under the MRI machine, and that's the transducer there. So we're awake, you're shaking. And then the surgeon is looking at the MRIs to be able to map out exactly the location that we want to go to and measure where we want the ultrasound waves to focus in on. And in the beginning, we do these low intensity where you get some increase in heat and temperature, and then we're going in to see, is that doing anything to your tremor? Are you getting control? And then we go back and forth to see if we can get more and more to really get to great tremor control without significant side effect. And then you get the higher intensity waves. People do complain and do have a pressure-like pain, especially based on how intense the wave needs to be to get your tremor control. They can complain of having a headache while it's going through. And then his tremor stops. So for how effective is this? For essential tremor, like I said, predominantly was studied in essential tremor initially. Very effective. Patients got about 80-90% tremor control. And at follow-up visits, they showed that reduction stayed at about 70% within the first, second months. And then the larger study that was done, the largest study was with 76 essential tremor patients. And they had about 40-50% tremor control at 3-4 month mark, and then there was this decrease. Overall, they said they had about a 40-50% benefit after a year of getting full tremor control. Adverse effects that were reported, if you did get some numbness and tingling, balance issues, which is something we do have to be very careful about and monitor carefully, especially with our Parkinson patients, because obviously Parkinson patients' balance is already a concern, and we want to make sure that that doesn't get worse post-surgery. So you are evaluated by our physical therapists before the procedure and again after the procedure to make sure your gait is okay. People who do have balance issues, generally it tends to be temporary. It will go away if you need a walker or something. Make sure you have that. But that is obviously a concern, and that would be something that we would bring up with you guys to have that honest conversation, that we would need to make sure your balance is not going to be too affected by this if there is already concern for it. So small studies, like we mentioned about that. Parkinson's disease, it's already to be looked at even for Parkinson's dyskinesia specifically, to see if we could get a reduction in dyskinesia and be able to help reduce medications. So we've gotten some positive benefits from that. This was our first patient. This was her tremor before starting, and then her tremor after. So significant benefit with great tremor control. This was the first time she loves to drink Pepsi, and she couldn't ever drink it prior to having the procedure done, and then this was the first time she had it without shaking or spilling it everywhere right after she had her procedure. And then in the future, are there other things that this could potentially benefit? It's being looked for, refractory neuropathic pain, looking at in those ways, and there's been small studies to show patients have gotten over 50% pain relief for patients who had no pain relief before. Smaller studies looking in terms of psychiatric conditions, OCD, anxiety, could be potentially beneficial in those areas. There we go. The negative parts of it, we do kind of keep this in mind. There has been reports of people whose tremor, anytime we're doing something new like this, and again, you're burning a hole in the brain. So in the beginning, we want to make sure you make the smallest hole possible. You don't want to overdo it to give a patient side effect. In that case, is there a potential that the tremor could potentially come back? There have been reports of people having sort of return of tremor a year or two out, the balance issues we've talked about. There are risks of this. Again, this is still a surgical procedure, to always keep that in mind. When you burn a hole, you can get some swelling and some side effects initially due to that swelling that could occur, and then you get treated with a steroid that sort of improves that aspect of it. It is, right here, not suitable for both sides. It is now, this past year, has been approved. It is FDA approved to get both sides done. Usually it's about at least a year out before you get your second side done if you do want to get tremor control for both hands. But that is a separate procedure in itself, and you have to be at least a year out before you consider it a candidate. Again, that's still very, very new. What does that do to your balance? What does that potentially do to your swallowing? These are all concerns before we would consider doing both sides, but to keep that in mind. If you can't have an MRI, you obviously can't have this procedure because it is done under MRI. If your skull is too thick, no matter what your spouse says, we do measure it and see. But if it is too thick, obviously, or too thin, then that would be a concern as well. It is still relatively new. We're still knowing, what can this do truly to benefit people. But again, to keep in mind, it is purely just to stop a tremor in itself. Future direction, I mentioned briefly, again, we're looking, I think this kind of excites me a lot more in terms of using this as a tool to open the blood-brain barrier to now start doing things like stem cells and doing things like gene therapies to get to where the target that we want it to go to without it going to other parts of your body and not ever getting to the brain. Small studies have been done to show there's been, not only can we open it and put in genes, but put in other microproteins and other particles into the brain to help sort of slow down the progression of neurodegenerative diseases like Parkinson's. There was a study in Alzheimer's. I know this came out, and it was a small study for patients that did open up the blood-brain barrier, and they visualized the hippocampus. They induced, ultrasound activity to the area. Was there improvement? Very, very, very small study. Mild improvement, not really all that significant. Was looked at Parkinson's disease dementia 7 patients that were looked at to open up that blood-brain barrier. But they were able to see that although there wasn't really much change in terms of motor symptoms or cognitive symptoms, but that the area did remain open for 24 hours to up to 14 days, which just indicates, hey, we can potentially open up this barrier. Now we could start getting in future treatments and future things there once now that we have that open. So I think that's all I have for this, but that's a quick and dirty on ultrasound. Thank you.